Thank you, Chairperson, and thank you, Diabetes India, especially Dr. Bansi Sahu and Dr. Amit Gupta for inviting me here. And I will, I will say this is the out of the box topic here because this is totally a metabolic sessions here going to be held again here. So beginning with the NAFLD and CV risk. So may I continue? So we are going to discuss the physiological changes in the cardiovascular system in the patient with NAFLD, describe the cardiovascular outcome, and evaluate the approaches to target cardiovascular risk in NAFLD trials, incorporate the CVD risk and risk reduction strategies. So we have the terminology now understanding the liver health. MAFLD is also known as MASHLD, non-alcoholic fatty liver disease, metabolic dysfunction associated with fatty liver disease. NAFLD affects around 30% of the world populations and is the hepatocellular part of the spectrum of metabolic syndrome, which compromises the obesity, atherogenic dyslipidemia, peripheral insulin resistance, type 2 diabetes, and hypertension. As a global prevalence of obesity and type 2 diabetes is on steady rise, NAFLD is regarded as a major public issue. NAFLD involves the atherogenic dyslipidemia, significant risk factor for cardiovascular disease, which is the leading cause of death in patients with NAFLD. Talking about the epidemiology, with the global prevalence of the NAFLD is a chronic liver disease affecting 30% of the global populations. And the prevalence rate of NAFLD and NASH among type 2 diabetes patients is 54% and 62.26% respectively. The rate of disease progressions are associated with age, ethnicity, genetics, and presence of comorbidities such as obesity, type 2 diabetes, and hypertension. The presence of dyslipidemia, hypercholesterolemia, triglyceridemia, or both has been reported as 20 to 80% of the cases associated with NAFLD. Prevalence of coronary vascular disease is 26% and cerebral vascular disease 20% and peripheral vascular disease is 15.4% with these studies. The prevalence of NAFLD general populations is 9 to 53% in Indian scenario, with the regional wise rural area has West Bengal 8.7%, coastal south 49.8%, which is the highest, and even the North India has the highest prevalence of NAFLD with a 53.7%. NAFLD in high risk Indian adults with obesity is 52.8% in type 2 diabetes. The prevalence of non-alcoholic fatty liver disease, we can find out only one studies in Nepal that was done in Kathmandu patient. So it was 49.4% of the patient have NAFLD. Type 2 diabetes population with dyslipidemia have 38% higher risk of NAFLD. So talking about the pathogenesis and progressions of disease, we have the non-modifiable factors and modifiable factors. So the modifiable factors that we have gut polymorphism, genetic polymorphism, gut microbiome, and environmental and social factors, dietary saturated fat or PUFA. So when the energy intake exceeds metabolic needs, because of the high intake of fructose, glucose, and sucrose, hepatic de novo genesis lipogenesis starts, which will increase the triglyceride level, deposition in the fat, deposition in the liver, which will lead to elevated cholesterol level and triglyceride, which will increase the risk of CVD. And further, if the free fatty acid deposition is there, oxidative stress, ER stress, and inflammation activation is there, which leads to phenotypes of NASH, fibrinogenesis, leading to fibrosis, and genomic of DNA damage, leading to hepatocellular carcinoma. And free fatty acids that will do the mitochondrial beta oxidations, leading to disease progressions. Risk factor for NAFLD and NASH, we have type 2 diabetes, that is insulin resistance, prediabetes, obesity, metabolic syndrome, elevated liver enzymes of greater than 6 months, and family history of cirrhosis. So how to detect this hepatic NAFLD, hepatic steatosis in adults? We have lean obesity in our Asian population. So we want to talk about the obesity or overweight as defined as BMI greater than 25 in Caucasian and BMI in greater than 23 in Asians. They are known as metabolic dysfunction associated with fatty liver disease. But in the lean normal weight patient, when the BMI is less than 25 in Caucasian and BMI is less than 23% in Asians, in that scenario, we need at least two metabolic risk factors. So that is waist circumference greater than 102/88 in Caucasian male and female, and blood pressure of 130 by 85, triglyceride level greater than 150, and pre-diabetes level 100 to 120, 125 in the fasting, and PP sugar 140 to 199, high level of CRP level, homeostasis model assessment insulin resistance score greater than 2.5. So we are linked with the diabetes, NAFLD and diabetes. So talking about the NAFLD and type 2 diabetes, when the hepatocytes increase mitochondrial beta oxidation leads to FFA that will lipid overload with further impair the mitochondria antioxidant capacity, leading to oxidative stress and mitochondrial leakage, aggravate the insulin resistance, and leading a link between the NAFLD and diabetes. When we have type 2 diabetes that is linked to NAFLD, in patients with type 2 diabetes, liver lipogenesis is elevated with hepatic uptake of fatty acids upregulated under the insulin resistance status, and with the excessive hepatic FFA influx in type 2 diabetes patients such as palmitic acid, cholesterol, lysophosphatidylcholine, and ceramides that will directly cause lipotoxicity and induce liver inflammations and fibrosis. NAFLD often coexist with type 2 diabetes. So there is a link between NAFLD and diabetes. We can see this slide. NAFLD leading to type 2 diabetes because of hepatic insulin resistance, glucose production increases, protein kinase increases, futin and RBP4 increases. And if the patient has the NAFLD, that will increase the triglyceride levels and lipid toxins that will lead to atherosclerotic diabetic nephropathy and diabetic retinopathy. And with the circulating free fatty acids and adiponectin and peripheral insulin resistance, that will again lead to fatty liver disease. So with all these things, NAFLD and and diabetes are interlinked with each other. Link between NAFLD and CV risk: at early stage, NAFLD can increase the cardiovascular risk. Special group: patient with NASH and advanced fibrosis with F3 and F4, patient with concomitant type 2 diabetes, patient who have high risk of cardiovascular events and mortality. And current evidence suggests NAFLD increases the risk of developing CVD, experiencing cardiovascular events. The overall cardiovascular risk results from the combination of NAFLD stays and other cardiometabolic factors. So NAFLD is also associated with insulin resistance, leading to resistance in the anti-lipolytic effect of insulin in the adipose tissue with the increase of free fatty acids. So when the triglyceride production increases, that will stimulate the secretion of VLDL in hepatocytes, leading to oxidative stress and lipid peroxidations, increasing the secretion of inflammatory markers, plasma glucose, and HDL concentration will decrease. That will linked with the increased risk of cardiovascular risk. So we have the complications, NAFLD related to cardiac complications like coronary artery disease, cardiac dysfunctions, coronary cardiac hypertrophy, heart failure, valvular disease, mitral anal calcifications, atrial fibrillation, and QTc prolongations. NAFLD is strongly related with the features of metabolic syndrome, that is insulin resistant metabolic syndrome, dyslipidemia, hypertension, leading to the cardiovascular and cerebrovascular disease. So we have the two hit hypothesis about the NAFLD progressions and complications. When we have the normal liver disease, most NAFLD exhibit benign simple steatosis progresses. 10% have the NASH with hepatocyte injury and inflammations. Approximately 20% of patients with NASH with advanced NAFLD fibrosis scoring F3 or compensated cirrhosis will progress to cirrhosis. Patients with NASH are at risk of developing hepatocellular carcinoma in the absence of cirrhosis. So there is always sedentary lifestyle, high fat intake, insulin resistance, and obesity that will lead to simple steatosis, which can be cured with the lifestyle management. But when the NAFLD reaches to MASH, it's very difficult to cure it. So we have the other complications: arthrogenic dyslipidemia, chronic kidney disease, osteoporosis, heart failure, sleep apnea, polycystic ovarian syndrome, malignancy. So how to diagnose this NASH? So we have the ultrasound, non-invasive score like APRI, FibroScan, NFS, and FibroScan, liver biopsy, and liver enzymes, lipid profile, and glycemic parameters. The management of NAFLD involves lifestyle modifications, pharmacological therapy, surgical approach. So lifestyle modification is the management relies in lifestyle changes. So including the diet and exercise, if we aim for the weight loss of 7 to 15%, we can risk the reduction of the NASH, simultaneously assess and treat the cardiovascular risk together. Surgical approach: in every obese patient, bariatric surgery is the primary treatment for weight loss, effectively improving or resolving the obesity-related metabolic complications. So exercise without weight loss produces 20 to 30% of relative reduction of steatosis. Different form of exercise with high intensity, intermittent aerobic exercise appear to have similar effects. Diet, especially the Mediterranean diet, works both for NAFLD and CV, more with dietary fibers, plant-based protein, unrefined grains, fish with omega fatty acids, legumes, and nuts. And we have the treatment options of pharmacological therapy. Therapeutic options for NAFLD and NAS. We have the statins for decreasing the cholesterol level in our body, and we have the mitochondrial beta oxidation can be reduced by the dual PPARY agonist, that is saroglitazar, which has been talked by Dr. Bhattacharya and others. And we can decrease the PPARY agonist pioglitazone, which can decrease the adipose tissue of fat storage capacity of liver by pioglitazone. We have the GLP-1 agonist that is also very useful. So first treatment option for NAFLD complications is complicated by CVD, lifestyle, physical activity, weight loss, energy restrictions, smoking cessations, and optimal medical therapy that we have for the CVD is aspirin, anti-diabetic medications, anti-hyperglycemic agents, and lipid-lowering agents, and bariatric surgery. So we can see some of the studies that has shown pioglitazone meta-analysis has shown greater efficacy in reducing ALT and AST compared to other drugs, and significantly improves the HDL and had little effect on reducing the LDL level. And statins prospective intention to treat studies has shown significantly decrease VLDL and LDL and increase the HDL, improves liver test, and reduce cardiovascular morbidity in NAFLD patient. Fenofibrates significantly reduces the triglycerides and LDL and has beneficial effects on treatment of fatty liver. And vitamin E significant has prospective and comparative observational studies with a vitamin E 800 mg has showed significant reduction in SGPT, SGOT, and triglyceride from baseline. So we have many drugs underlying. So we have pioglitazone, rosiglitazone, and saroglitazone, PPARY. We have got microbiota dysbiogenesis with solely through mycin. We have the GLP-1 agonist with liraglutide and semaglutide, tirzepatide, and we have the SLT inhibitors, canagliflozin, dapagliflozin, empagliflozin, and other drugs like pentoxifylline and FXR. They all are on the queue of trials, and many research are to be made there. Vitamin E is still not recommended in type 2 diabetes, but we can practice that in our only NAFLD patient without diabetes, only in patient with proven biopsy, NASH without diabetes actually. Long-term use increase the risk of prostate cancer and hemorrhagic stroke. And thiazolidinones have the associated with weight loss, peripheral edema, increased risk of heart failure and bladder cancer. So we should be cautious about using the pioglitazone in our patient with NAFLD and type 2 diabetes. And it is associated with osteoporosis in menopausal females. So in that scenario also, we need to be more cautious about it. So limitations of existing therapies. So finofibrates with a low potency, limited selectivity of PPRA associated with increased risk of myopathy, cholelithiasis, vein thrombosis, declining renal functions, and elevated transaminase. Studies with fibrates in NASH has no significant improvement in steatosis or fibrosis. Statin does improve lipid profile, but not beneficial on liver biopsy, liver histology in patient with NASH. So therapeutic options for NAFLD with comorbidities NASH include PPRS, nuclear receptor, regulating metabolism, inflammation, growth, and differentiation. Glitazar we have now, sologlitazar acting on PPARA and PPARY, tackled by NAFLD issues, dyslipidemia and insulin resistance. Development of tesaglitazar, muraglitazar, and aliglitazar for DD treatment for was halted due to because of adverse effect linked to significant Y actions, and saroglitazole with predominant PPRA effect on moderate PPRY effects lacks the side effects. So still saroglitazole is preferred choice for the NAFLD with comorbidities and cardiovascular risk. Thank you so much.